Buenas noches a todos. Nuevamente, bienvenidos a esta segunda sesión del programa que estamos desarrollando en conjunto con la Sociedad Norteamericana de Gastroenterología, Hepatología y Nutrición Pediátrica. Hoy vamos a tener una conferencia extremadamente interesante a cargo de alguien que nos acompaña, se conecta desde Chicago, la doctora Cohran, a quien vamos a presentar de inmediato, y quien va a estar moderando la sesión es el doctor Spolidoro, quien se conecta desde Porto Alegre, en Brasil. Por supuesto, igual que toda la semana, quiero darle la bienvenida también al doctor Benjamin Gold, el presidente de NASPA, que nos acompaña esta noche. Benjamin, how are you? Hello and welcome.
Thank you, Reynaldo, and greetings, everyone. We're excited again about the second in this series of NASPGAN Visits LASPGAN, and what the hope is of an educational series that will be enduring, as well as stimulating ongoing collaboration and partnerships between our two organizations in more ways than even we could have imagined. I'm really excited about the topic this evening and to have Professor Cohran talk to us this evening. And again, thank you so much and greetings, everyone.
Thank you. Thank you all for being here, for sharing your experiences with us. So, para entonces poder continuar con la sesión, yo voy a dejar con ustedes al moderador de esta sesión, que es nuestro vicepresidente, el doctor José Vicente Spolidoro. Spolidoro es, por supuesto, pediatra, gastroenterólogo, nutrólogo, es profesor de la Pontificia Universidad Católica de Río Grande del Sur en Porto Alegre, Brasil, donde reside y ejerce sus funciones académicas y médicas y científicas, y desde allá se conecta con nosotros. Así que, Spolidoro, te doy la bienvenida y te cedo entonces el resto de la noche para que compartas con nosotros y con la doctora Valerie, que se conecta desde Chicago. Bienvenidos y gracias.
Buenas noches a todos. Reynaldo, muchas gracias por la presentación. Dr. Ben Gold, thank you very much for giving us a chance to take this excellent course. This is the second one, and it's going to be, I'm sure, a very good one. I'm going to introduce Dr. Valerie Cohran. She is going to be our speaker. She is medical director of the Institute of Rehabilitation and Transplantation at the Children's Hospital of Chicago. She is a professor of the School of Medicine in the Western University in Chicago as well. So she's going to talk to us about intestinal failure, the TPN intestinal failure, these characteristics. And I'm very pleasure to introduce you. And Dr. Cohran, please.
Well, I would like to thank LASPGAN and NASPGAN for this wonderful opportunity. I look forward to answering questions after the talk is done.
Wonderful. Your talk, and afterwards we will be chance to answer some questions. So you afterwards can, para todos que están nos asistindo, pueden enviar questões por chat. Nosotros vamos entonces transmitir las cuestiones para la doctora Valerie. Entonces, poderemos então discutir todos os aspectos. É com muito gusto, então, que vamos empezar sua apresentação. Muitas graças.
Hi, my name is Dr. Valerie Cohran, and I would like to thank the organizers of this conference for inviting me to talk. And my talk today will focus on the state of intestinal failure 2021. I am at Lurie Children's Hospital in Chicago, where I'm the Associate Chair for Diversity and Inclusion, in addition to being the Medical Director for Intestinal Rehab and Transplant. This is a list of my disclosures, which I will talk about later within the talk. What are the objectives of this talk? I want to discuss, or the learner should be able to recognize predictors of enteral autonomy, I'll discuss intestinal rehabilitation programs and also review new innovations for caring for intestinal failure patients. When you look at this slide from 1968, which showed an infant who received TPN for a brief period of time, and this is the first patient who was reported to receive long-term TPN. Unfortunately, this infant died, but this work by Wilmore and Dudrick actually were the forefront of what we now know as modern TPN management. First, let's talk about intestinal adaptation. When you think about patients who have intestinal failure or short bowel syndrome, it's very important to know the norms for intestinal length. How much length do they have, and how much that was actually taken out or removed. When you look at the patients, especially when they're earlier in their gestation, maybe 24 to 26 weeks gestational age, the norms are about 70 to 75 centimeters of bowel. So if you understand that the patient maybe have 35 centimeters of bowel remaining after a surgery, you put that into context, that means they still have about 50% of their bowel. And it's really during the third trimester of pregnancy where the intestinal length doubles. So this child may in the end have a decent amount of bowel. As you know, the older the patient becomes, the more intestine they have, and unfortunately, to a certain extent, the less ability for them to compensate for losses at times. There are structural and there are functional changes that occur during intestinal adaptation. The structural changes that the bowel undergoes after resection include hyperplasia, angiogenesis, bowel dilatation, and bowel elongation. When we think of the functional changes that occur, there are increases in a variety of receptors, transporters, cells. You hopefully have increased cell crypt differentiation with hopefully slower transit time, and also an increase in nutrition and fluid absorption. This work was published in 2012 from 14 intestinal rehabilitation programs within North America. So this is from the Pediatric Intestinal Failure Consortium. So they enrolled infants in this retrospective study who had TPN for at least 60 days or more, and they were defined as attaining enteral autonomy if they were able to be weaned from TPN greater than 3 months. These infants were cared for between the time period of 2000 to 2007. So over 20 years ago at this time. When you look at these patients and look at the outcome, about 47% of these patients were successfully tapered from their TPN. Unfortunately, about 26% of these patients died. An additional 25% of these patients underwent intestinal transplantation, with an additional 17% of these patients dying. So at this time period, typically you would say about half of the patients did well and were able to be tapered from TPN. And unfortunately, the other half either died or underwent transplantation. This is work that was done by Dr. Dan Teitelbaum's group in 2015, and he looked at patients that they had followed for up to 6,000 days. There were 171 infants or children that were enrolled in the study, and they were broken down based upon the small bowel length that was expected. As you can see, the x-axis is the percent of patients who are still TPN dependent. So the patients who are in red are those who had greater than 50% expected bowel. And as you might imagine, and as we know in practical terms, majority of those patients are able to be tapered from TPN, and they were tapered within the first 1,000 days. And as you can see, the time shifts a bit depending on how much intestine was left. What I think is also very crucial in this graph is if you look at the patients who had less than 10% expected bowel. So these patients were very short. When you look at this cohort, less than 10% expected, about 35% of them were tapered from their TPN, which is much greater if you think about it, that one person may expect these patients to be tapered. So I think it's interesting, and I think it's important to remember that even if somebody's ultra short or has less than 20, 30 centimeters of bowel, there still is the potential for them to be tapered from TPN. What about the diagnoses for outcomes? Again, looking at that same PIVCon data set, they looked at patients and divided into those who had necrotizing enterocolitis and those who did not. Again, over the follow-up of 72 months, clearly those patients who had NEC, 65% of those patients were able to be tapered from TPN. However, when you look at the patients who did not have NEC, so these were gastroschisis patients, patients with volvulus, patients with intestinal atresia, they were less likely, closer to about 40% of those patients being able to be tapered from TPN. Another sign of predictive value was the presence of the ileocecal valve and longer remnant length, which is very customarily accepted to be a reason or patients to be tapered from their TPN. This is the group at Sick Kids who published another cohort of 120 children from 2006 to 2013. So again, this is about, right after that immediate time course for the PIVCon data set. 70% of their patients were able to be tapered from TPN. Those patients had less mortality than what we saw in that previous study. And of course, these patients, the more residual bowel they had in colon, they did better. Those who had an ileocecal valve and those who had less infections. So if you compare the 70% of enteral autonomy in this cohort and the 47% who obtained enteral autonomy in the earlier cohort, clearly over time, we're making a difference in being able to help patients survive and attain enteral autonomy. And I'll talk about intestinal failure associated liver disease shortly. The same group also tried to devise a severity category score. So by using or looking at a variety of factors, small bowel length being greater than 50%, the presence of the ileocecal valve, patients being able to absorb or tolerate greater than 50% of their enteral calories at 6 months of age, and having a low bilirubin. So as you can see, based off of the scoring, those who had mild disease or higher scores, 97% of those patients in theory would be tapered from TPN. When you look at those who were in the moderate category, about half of those patients would be tapered in TPN, and the severe, 0 to 2, about 25% of those patients would be tapered. Another predictive value for patients with with intestinal failure is looking at small bowel dilatation. And this paper was published in 2017, and it predicted prolonged parenteral nutrition needs and decreased survival in patients with short bowel syndrome. So there were 61 children who were cared in this cohort from 2002 to 2015. They're about 1 year median age, and they had 169 imaging studies. And they looked at the small bowel width as millimeters and also a ratio to the L5 vertebrae. Similar what you would see in most patients that are followed in an intestinal rehab program. They had necrotizing enterocolitis, volvulus, atresias, and gastroschisis. So when they looked at these patients and they looked at the proportion of the patients who remained alive compared to their small bowel ratio, as you can see, based off of these 49 measurements, those patients who had less dilatation overall were more likely to survive than those who had greater than 3 with regard to their ratio. When you looked at each individual measurement that the patient had actually had, again, Patients who had significant small bowel diameter ratios greater than 3 were more likely to die as compared to those who had between 2 to 3 and less than 2. When you go and look at specifically the hazard ratios, those maximal small bowel diameter ratios who were less than 2, so these patients were less dilated, they were almost 18 times as likely to be tapered from their TPN as compared to those patients with 2 to 3 centimeters and the reference, which was greater than 3. Also, what they found were those patients who, of course, who had more small bowel length were more likely to be tapered from TPN, and also those patients who had their ileocecal valve preserved were 5 times more likely to be able to be tapered in multivariate analysis. So, predictors of enteral autonomy. We have discussed remnant intestinal length. We've discussed diagnoses, the presence of liver disease, the presence of the ileocecal valve, and small bowel diameter. The next focus of my talk, I will discuss the rise of the intestinal rehabilitation program. So NASPGHAN published a review statement, a position statement in 2017, and they defined intestinal failure as patients requiring TPN for greater than 60 days, or a remnant bowel length less than 25% expected. And patients met criteria if they met one or both of these factors. And these patients should be referred to an intestinal rehabilitation program for consultation or for clinical management. Other patients, or the second recommendation, was that patients who are not doing well, who are clinically complex, progressing with TPN for greater than 3 months, who have worsening or non-resolving liver disease, recurrent sepsis, loss of access. These patients should have access to an intestinal rehab program for consultation and management. When you think about the bare minimum of a team, now this is the ideal team, the slide courtesy of Jeff Rudolph. You have the gastroenterologist, you have surgeons, intensivists, therapists, social workers, dietitians, cannot forget the dietitians, clinical nurse specialists, extenders, interventional radiologists, and the gastroenterologist. And we're all focused on taking care of this one patient. But depending on where you are and depending on the resources you may have, you may not have access to all of these types of healthcare providers. The bare minimum is thought to be a gastroenterologist, a surgeon, a dietitian, and a nurse to help with these, take care of these very complex patients. When data has been examined looking at patients who were followed within intestinal rehabilitation programs as compared to those who were followed pre-creation of intestinal rehab programs, as you can see with these variety of studies, those who were followed with intestinal rehab programs overall were less likely to die. They were less likely to die from liver failure, less likely to die on the waiting list, and they had less sepsis as compared to those who were not controlled or taken care of within an intestinal rehab program. So this data would suggest the usage or intestinal rehab programs do improve outcome of these children. This is data looking at sick kids, and they looked at the creation of their intestinal rehabilitation program and looked at other factors that may actually improve outcome. And what they ultimately found that mortality decreased over time for their cohort of short gut patients that were cared for within an intestinal rehabilitation program and with the use of omega-3 fatty acids, which I will talk about later. Next, let's discuss new innovations in caring for our intestinal failure patients. Intestinal failure-associated liver disease. When we think about intestinal failure-associated liver disease, previously known as PNOLD or PN-associated cholestasis, we know that up to 2/3 of children will have some sort of intestinal failure liver disease. Up to 25% previously of these patients would go on to develop liver failure. If you look at the graph or the picture on the side, this is a picture of a liver biopsy of a long-term TPN patient. And unfortunately, you see the green arrows, which are pointing to areas of cholestasis or bioplugs. We do know that IFELD is multifactorial in origin. Quite unfortunately, we don't know exactly what causes it depending on the patient. We know prematurity does connect to this or is related to this, low birth weight, lower remnant length, duration of TPN dependence, sepsis, bacteremia, lack of enteral nutrition, and components of the TPN. As a physician caring for the child at this point, you cannot go back and significantly change what's previously happened. But what you can do is you can have an effect on what you're providing for the patients with regard to the components of their TPN. Again, referring back to that PIVCON data set, this study looked at those patients and described their outcome based off of their baseline conjugated bilirubin. And as you can see, they were divided into less than 2, 2 to 4, and 4 and greater, and looked overall at their mortality. And as you can imagine, especially during that time period, which was the early 2000s, over a third of the patients, 30% of those patients who had bilirubins greater than 4, unfortunately died. I think now it's very well accepted that the soy-based lipids are part of the issue, or a very important part. So phytosterols, which are present in soybean-based lipids, were found to be elevated in children or patients receiving TPN, thought to promote cholestasis, triggering inflammation, increasing oxidative stress, displacing cholesterol. And there's definitely data to suggest both kids and adults who are receiving greater than 1 gram per kilo of lipid will have cholestasis develop. Omegavin, or the omega-3 fatty acid product, which I previously mentioned, which one of the reasons that improved the outcomes for the patients and sick kids, is an IV fish oil. And it's thought that it has immunomodulating effects on the liver. You have less impairment of biliary secretion. You increase the omega-3 fatty acid to omega-6 ratio in the red blood cells. So omega-3 fatty acids are beneficial. They thought to have an anti-inflammatory effect. They also probably have less of a pro-inflammatory effect. And there are no phytosterols. And remember, phytosterols are present in the soy-based lipids. This was approved in the United States in 2018 for usage for TPN cholestasis. So more and more patients are receiving Omegavin, which previously was not available to them. One thing that must be remembered is that even though patients may receive Omegavin, it is not a cure-all for everyone. This is work that was done from the group at Boston Children's, who's been the leader with the use of Omegavin in the United States. And they looked at, retrospectively, patients from 2004 to 2014, 182 patients. And their outcomes was the resolution of cholestasis, and treatment failure was defined as a need for transplantation, and death while bilirubin greater than 2. 86% of the children actually had resolution of their cholestasis. But what's important to remember is that 14% of the patients did not. They tended to be of lower birth weight. They tended to be older at the time of TPN initiation. They had higher PELD scores, so ped end-stage liver disease scores, lower GGT, and higher direct bilirubin. What were the independent predictors that they found that would suggest treatment failure? Well, patients who had PELD scores greater than 15, so those patients were 7 times as likely to fail Omegavin therapy. Those who had GI bleeding, those patients who had greater than 16 weeks of age at initiation, those with mechanical ventilation, and those with non-GI comorbidities. So anywhere from 3 to 5 times as likely to have a poor outcome. So again, I think this emphasizes that we are learning more and more about intestinal failure liver disease, but we still do not know or understand all of it. And I think that it's important to know, even if you can use Amigaven and you have access to it, you still need to be aggressive in order to try to taper the patient from TPN, because fish oil is not going to cure everyone, unfortunately. One of the newer lipid products that's also available in the is SMOF. So it's approved for in the US for adults in 2016. It consists of soybean oil, MCT, olive oil, and fish oil. So you have a combination of different products in this product versus the fish oil, which is just 100% fish oil, and the soybean-based one, which is 100% soybean. So it's thought that these other products also have an anti-inflammatory effect and can be beneficial. When it's used in pediatrics, it's being used off-label. It does not have an indication in pediatrics currently. So when we talk about intestinal failure associated liver disease, we know that soy-based lipids have been linked to cholestasis. Persistent cholestasis portends a worse outcome, death, or the need for transplantation. Fish-based lipids have been shown to be effective therapies, and early referral to intestinal rehabilitation may be beneficial. What about the role of endoscopy in caring for intestinal failure patients? I think when we typically think of the symptoms and the that the patients are having, we always attribute it to them having short bowel. They're missing a lot of their intestines, so it should be expected that they may have looser stools. It may be expected they have evidence of bacterial overgrowth. But I think this is a new and exciting area with regard to caring for patients who have intestinal failure. We frequently know these patients have small bowel bacterial overgrowth for a variety of different reasons. They can have nausea, vomiting, abdominal pain, so there may be clinical symptoms that are suggesting this is the problem. They can translocate, so they may have bacteremia. They can have worsening liver disease as a result. We know that some patients who have intestinal failure, short bowel syndrome, have food allergies. They may be allergic to milk. They have eating disorders or oral aversions, especially when they weren't allowed to eat early on, and they may have poor growth. You may see evidence of mucosal injury from the bacterial overgrowth, whether it's villus atrophy, malabsorption, permeability. And again, poor intestinal motility, abdominal distension, you may have a lot of stools or decreased stools, and that can go back to having bowel dilatation, as I had mentioned previously. So this work looked at common organisms and small bowel bacterial overgrowth in patients with intestinal failure. So there were 57 children with a median age of 5, and they all underwent an endoscopy to obtain a duodenal aspirate. So small bowel bacterial overgrowth is defined as greater than 10 to the 5th colony forming units per milliliter. When you look at the diagnoses that these patients had, 28% had motility disorders, 16% neck, atresias, gastroschisis, and also Hirschsprung's disease. 70% of the patients had evidence of bacterial overgrowth based off of these duodenal aspirates. Patients who were still receiving TPN were more likely, 70% versus 35%, than those patients who were not on TPN to have bacterial overgrowth. And they also noted that PN administration was associated or being 5 times more likely for those patients to have bacterial overgrowth. When you look at the variety of organisms that were actually identified, you also saw gram-positives, candida, but you saw a variety of gram-negative organisms, which we very commonly see when we care for these children. Klebsiella variants, Enterobacter, Pseudomonas, E. coli. And duodenal aspirates may actually lead to the tailoring of your antibiotic regimen. How do we treat bacterial overgrowth? There are a variety of different ways that everyone does this, whether it's Cipro, metronidazole, rifaximin, nystatin, antacid reduction. So it just really depends on where you are and what you have access to. But I think what's also very important, as I mentioned previously about small bowel dilatation, please have a low threshold to obtain radiologic studies. Do not treat an obstruction with antibiotics. So if you have a patient who's having recurrent bacteremia, obtain an upper GI study. If you have somebody who's having significant changing in their bowel pattern, more distended, please do a contrast study to see, does this patient have dilatation, and is this something that needs to be addressed? This was a paper that was published 2019 that discussed screening endoscopy, and it talked about the modifications of the therapeutic regimen in patients who had intestinal failure. They had 56 patients with a mean age of about 70 months, ranging anywhere from 3 months of age to almost 17. 89% of the patients were dependent upon TPN. When you look at the diagnoses, most of these patients had intestinal failure, short bowel syndrome. You also had patients who had motility disturbances and also mucosal lesions. 83% of these patients had abnormal endoscopies. So let's break that down further. They had patients that they simply screened, and that was 45. And they had patients who actually had symptoms, and that was 11. So when you look at those patients who actually were just screened, a significant portion, almost 70% of those patients had abnormal findings. Now these patients they were not symptomatic. When you look at the patients in group 2 who had symptoms, 82% of them had abnormalities. When you look at the ileoscopies, 100% of both groups had abnormal findings, and you had treatment changes, which is true for both enteroscopies and the EGDs. You change, or they change, the medical management of these patients based off of the findings in their endoscopies. And when you look at the colonoscopies, 50 to 75% of those patients also had symptoms or found to have abnormalities. So what exactly were the abnormalities that were actually found in these patients? Patients for the esophagus, you may have seen esophagitis, stenosis. You had patients who had abnormalities in their stomach. Did they have gastritis, ulcers, evidence of stenosis? Did they have ulcers in their duodenum, erosive duodenitis, erosive inflammation in their bowel, ulcers, or dilatations? What about the small bowel findings that were noted? Some had polypoid lesions, stenoses, evidence of bleeding, enteritis. And even in the colon, some of these patients had colitis, they had stenoses. One patient actually was found to have rectal varices, again in that group 1, the patients who underwent it because of screening. So I think this data would suggest that endoscopy is important in the armamentarium of caring for patients who have intestinal failure. To diagnose bacterial overgrowth, obtaining duodenal aspirates may lead you to tailor the antibiotic regimen that you're going to use. And you find other diagnoses, whether it's inflammation, ulceration, strictures, stenoses, that may change your medical management and that can potentially help enhance the likelihood of the children obtaining enteral autonomy. So I talked previously a little bit about lengthening procedures, or rather dilatation of the bowel. So when the bowel is dilated, most people think between 4 and 5 centimeters on contrast study on an upper GI. That's concerning. What are some of the frequent complications of dilated loops of bowel? Recurrent bacterial infections, plateau in enteral tolerance. Perhaps you can't advance the child's feeding. TPN-associated liver disease, not cirrhosis, vomiting, and refractory D-lactic acidosis. And the goals are to enhance tolerance and to restore the normal bowel caliber and function. This is why it's so important, if patients are having symptoms, to consider a contrast study, because perhaps there's surgical intervention that can be done. When you think about the new frontiers for caring for patients who have intestinal failure, GLP-2 or glucagon like peptide 2, I think has really made a significant impact. And more these types of drugs are coming down the pipeline. So GLP-2 is a hormone secreted by enterocrine cells in the distal ileum and proximal colon, key component to the adaptive response. And what's interesting, as we know, commonly our short bowel patients are missing the distal ileum in their proximal colon. So teduglutide is a recombinant form of this GLP-2 analog, extending the half-life. And it enables reduction in parenteral support in both pediatric and in adult patients. It is a 33 amino acid long peptide, and it promotes mucosal growth. It enhances crypt cell growth, inhibits apoptosis, decreasing gastric motility and secretions, increasing mesenteric blood flow, and reinforcing the gut barrier function. This was a study that was published in 2019 that subsequently led to its approval by the Food and Drug Administration. So there were patients who were underwent double-blind randomization to teduglutide, either the 0.025 milligram per kilogram daily dosage or the 0.05 milligram per kilogram. There was also a standard of care group, so parents who elected not to pursue the drug, but wanted to be monitored more closely, essentially. And so these patients received therapy for 24 weeks with follow-up at 4 weeks. After that time period, a subset of the patients continued in the extension trials. When you look at these patients, you had about 24 patients that received 0.025 milligrams per kilogram per dose daily versus 26 patients who received 0.05 milligrams per kilogram. As you look through each of the demographics, you can see they were fairly similar. They had patients in both groups who had neck, volvulus, atresias, Hirschsprungs, and gastroschisis. One of the important outcomes that was evaluated was looking at the decrease in the amount of parenteral support that was actually provided, a decrease by 20%. So you can look at the table, which shows the teduglutide group in the 0.025 and the 0.05 group. If you can tell, 54% of those with the lower dose of teduglutide still had more significant decrease in this primary endpoint as compared to the standard of care. The same being true of 69% of the higher dose of 0.05 milligrams per kilogram dosage versus the standard of care. So 38% of the patients overall had a reduction of at least 1 day a week of their parenteral support, with a mean decrease in 3 hours. Who are patients that are being considered for GATAX? These are patients who are greater than 1 year of age, patients who can tolerate a daily injection because that's what it requires, initial monitoring for fecal blood, with the concern being that there may be development of polyps due to the use of this drug. So patients are screened at about a year after therapy. You have standard labs, including amylase, lipase, alkaline phosphatase, and bilirubin, and some of these are already done with their standard TPN screening, and annual fecal occult blood and endoscopy every 5 years. So, what are some of the adverse effects that were actually described with GATAX? Greater than 10% of these patients had abdominal pain, nausea, distension, reaction to the injection site, vomiting, overload, abdominal distension, hypersensitivity. But what's interesting is these are some of the symptoms you would see normally in a short bowel syndrome patient, especially the abdominal pain and nausea. So in May 2019, its drug has been approved for patients greater than 1 year of age and older with short bowel syndrome who are dependent upon parenteral support. I think if you look over the course of the last 20 years from caring from these patients, we've definitely made a significant impact on the outcome of these children. So this is data that I obtained from the UNOS data set that looks at intestinal transplants, pediatric, 0 to 17, from 1990 to 2020. It was in 2011 that it really peaked at 111 patients in the United States. And you look more recently, it has significantly declined. Why do we think this is? I would beg to argue that it's because of the invention or the creation of intestinal rehabilitation programs, whether it's related to surgical interventions, is it related to different types of lipids, alternative lipid products, so we have less patients that have intestinal failure liver disease? Is it due to just the comprehensive care that they're receiving? Whatever the reason, we do know there's a significant decrease in the amount of intestinal rehabilitation, the amount of intestinal transplants that are actually done as compared to previous. So at this time, I would like to take any questions. Thank you so much.
Go ahead, Dr. Spolidoro. Go ahead.
Excellent. Thank you very much, Dr. Valerie. We already have some questions for you. I have a question regarding the omega-VN that was used in the group for treatment of cholestasis. And I'm having a returning delayed.
Spolidoro, disculpa, ¿podrías decir la pregunta en español, por favor?
Sí, sí.
¿Podrías hablar en español?
I'm going to do in English first for her, and then I will do in Spanish. So the question is regarding the omega-VN that is used for patients that to treat the cholestasis, and they asking about the dose that was used. Há uma pergunta cá sobre a dose utilizada de omega-VN para el manejo de colestasis en los niños que mejoraron de la colestasis con el cambio del lipídio.
So the standard dose for omega-VN is 1 gram per kilogram.
Tá. Carlos, há delay muito grande.
We don't have any delay now.
For me, it's a very long delay.
Turn off the Vimeo. Turn off the Vimeo and listen through Zoom.
Spolidoro, tal vez si te vas a la sesión de Zoom. ¿Tú estás en Vimeo o estás en Zoom?
Tá. Estou em el vídeo acá.
¿Por qué no te vas a Zoom?
Sí. No, lo salí del Zoom, ¿no? Estoy en Zoom ahora.
Okay.
Okay. Okay.
¿Está bien? Entonces, could you answer again the question, please, Dr. Valerie? Because
Sure.
There was a little...
It's 1 gram per kilogram of body weight.
Okay. I would like to ask you, I heard, we read all these papers regarding this dose of omega-VN, and even they used this dose for a long period of time. I have my questions regarding the essential fatty acids and the amount of lipids, that it's very short amount of lipids, which I understand patients will have to use much more glucose to give the amount of calories that they need. So I'd like you complete your answer regarding this. I'm going to do in Spanish before to say. Yo pregunté también que ella, como dice, la dose es una grama por kilo, que lo pregunté que cuando usaron omega-VN, usaron omega-VN por período muy largo. La pregunta es sobre cuánto que hay tido de problemas con deficiencia de ácidos grasos esenciales, así como también usando tan poco lipídio que la cantidad de glucosa tenía que ser muy larga. Entonces, esa es la cuestión. Por favor, Dr. Valerie.
So, you are correct. You can, there is some risk of essential fatty acid deficiency, and that's why we check the levels serially to make sure. Some people have given higher doses of the Omegaven. 1.2, I think, is the highest that my institution has used. I've heard up to 1.5 grams per kilogram. The hope would be if you're able to advance feedings, you're also getting some fat and essential fatty acids within the oral or the enteral feedings in addition to what you're getting IV, but it can be an issue.
Okay. There is a question here regarding what's your take on the ileocecal valve being a predictor of enteral autonomy, its value or its proxy for terminal ileum. La pregunta es la importancia de la válvula ileocecal como predictor de la autonomía enteral sobre las válvulas, se é tem a ver com a quantidade de ilho terminal ou é a válvula ileocecal. Por favor.
So, as I had mentioned in the paper, there were several papers that suggest that the ileocecal valve does produce or suggest better outcome. And part of it may be that it is a proxy for the terminal ileum, but there's also data that says the ileocecal valve doesn't predict outcome. So, you know, I think of it as a good predictor, but I don't use it as my only predictor that children will be able to pump or be able to be tapered from their TPN. I think it's great if you have it. If you don't, you just have to deal with the consequences and go from there. But I do think the ability to break from the slow transit, and then also probably part of it is a proxy for the terminal ileum.
Yeah. This question came from Dr. Natasha, that it's working in Toronto, and in the schedule of that this predictor index that you showed in the slides. So the ICV is part of that that index.
Yeah. No, sorry, I was just saying, like, definitely that paper suggested, that PivCon paper suggested that the ileocecal valve is predictive. And then there are other papers that suggest it doesn't. So I think it's still, I find that it's beneficial, but I don't think it's the only main, I don't think it's the main reason why somebody will be able to be tapered from TPN.
Okay. I have a question here regarding the SMOF solutions, emulsion. I would say that in South America as well, in Europe, SMOF is not off-label for pediatric. That's it's being used as much as we would like. And the question is regarding what you think about the use of SMOF as a prevention, as to use even before to have IFAD, or if you think that's only when the patient has a liver problem that we should use SMOF. La pregunta es lo uso de SMOF se está indicado como una prevención o se puede usar o se debe usar para tratamento o se puede usar como una prevención para no hacer los problemas hepáticos.
My preference is if you, the patient is going to be on long-term TPN, I would initiate SMOF sooner rather than later. You know, there is some data that suggests that it is preventive for PNOD, and then there's data that says it's not. And I think we need more studies on that, but theoretically, you would think it would be helpful given the other types of fat that you have present, like the fish oil, the olive oil, all these other antioxidants that in theory you would hope would be less pro-inflammatory and would also decrease the risk of cholestasis.
Yeah, in the papers that we've seen that really the SMOF didn't show any difference with soy. I understand that they use the low birth weight babies that use a short time TPN, and I think that short time TPN probably doesn't make a difference to use SMOF or not. But when you have a patient that with a long time TPN, I think that's really make a difference. I don't know if you agree with what I'm saying.
No, I agree. If there's somebody and you know they're going to be on long term, and then I just tend to initiate them on SMOF if it's at all possible.
There is a question regarding the evidence to use heparin on TPN in neonates and children. What you think about?
Heparin as to decrease clotting. In what way is the person referring to using heparin?
Excuse me?
Just to clarify, is she referring to heparin just to kind of help keep the line open, or is there another reason?
I think that it's a lock of heparin, or I think that's a lock, because I don't know if I think that is probably for a lock.
For the lock. You know, I don't know if there's much evidence to support the use of a heparin lock as far as trying to prevent infections. I think there's, more data showing that the ethanol locks, the kite locks, which I know that are partly available in Europe, and the terulidine locks have been shown to be efficient. I'm not aware of significant data about the heparin locks being that beneficial.
And what you use alcohol?
I typically use alcohol, but it's become pretty expensive in the US, so I've been using it less. And I've started to use more antibiotic locks, trying to tailor them towards the recent infections.
Which kind of antibiotics you have been
varies. I have used Ceftaz, I have used Vanc. Those are probably the primary ones. Some institutions have used gentamicin locks. I think ethanol overall is probably the best if you have access to it, because it's just more broad spectrum and you're less likely to get any resistant organism.
But if the patient doesn't have any infection, it's just a lock for a daytime when it's off TPN.
So I don't usually use the locks unless you've had several infections, because I always worry, especially with the smaller infants, that I could clog the line when they're trying to withdraw it. So you have to, for me at least, have to have several infections before I will treat you with any kind of lock therapy.
And if you don't have infection, what do you use for a lock?
No lock.
No lock?
No lock. No, if you don't have an infection, I won't use a lock. I mean,
saline. Use saline.
Right, saline or heparin, but no, there's no other kind of lock like an antibiotic lock I'm using.
Okay. That was other question. There is a question regarding the bacterial growth. What you prefer to use as a cycle antibiotic for your patients? So you said that you look for an endoscopy, which bacteria may be, but what you use to give for them?
So I want to clarify. I think endoscopy is going to play more of a role with time, but to start off with, I don't necessarily do an endoscopy. And my first line choice of antibiotics is metronidazole.
What's the amount of lipids that you use to give for a patient that is starting on TPN for short bowel, for example, and but doesn't have any problem at this moment, is starting the treatment? You may think, as you said, to give SMOF, and how many grams per kilo do you use to give for I would say, infant baby? It's a 1-year-old baby. What you use? What's the amount?
Sure. I mean, I typically will start off with 1 gram per kilo, and I will increase it as needed up to 3 grams per kilo.
Wonderful. Okay, very good. And if you have a patient with low platelets count, do you change the amount of lipids or not?
Well, I usually worry if they have low platelet counts, do they have portal hypertension or do they have end-stage liver disease? You know, the platelets have not been as big of an issue for me with the use of SMOF, but I would worry, does that patient have another reason why their platelet counts are low besides just the SMOF?
Mm-hmm. There is another question here. The bowel dilatation is associated with a lower chance of TPN winning. What is the role of the physiological dilatation related with intestinal adaptation?
I think the issue is that you have poor motility in that dilated loop of bowel, and that's promoting bacterial overgrowth. And the bacterial overgrowth is going to lead to whether it's vomiting, whether it's distension, whether it's translocation, diarrhea, more problems with enteral advancement of their feeding. So I think that's part of the concern when you have significantly dilated bowel. It's not working properly and you're going to have complications from that, whether it's infections, whether it's vomiting and feeding intolerance.
Okay. There is other question regarding to use I don't know exactly what it is, APRI as an index for invasive, no-invasive hepatic fibrosis. Do you know what I mean? I don't know exactly which is APRI.
APRI, yes. I've seen it used in clinical studies and research papers, but I've not seen it really used as significantly in true clinical treatments.
Okay. Talking a little bit about the teduglutide. Let me ask you, there is even a very recent paper from the Spain group that's a real life, which they used for a period long of teduglutide and found 11 of 16 patients in it's a multi-center study in Spain with the patients that was out of TPN. It's a really very nice results. What do you think about how long could these patients that really get off of TPN, how long they should use the teduglutide? They should use for whole life? You think that sometimes they will be off? Do you think that there is any special patients that can be off teduglutide in some time? Should we choose best patients to give teduglutide? That's some questions that we have that we still don't use here in Brazil. In South America, only Argentina has been using teduglutide.
So I think, I think teduglutide is definitely can be beneficial. If you look in the studies that were used for FDA approval, there was not as much enteral autonomy gained, maybe about 10% in the pediatric studies, patients to be tapered from their TPN. So the Spain study is definitely showing increased, more patients were able to be tapered from their TPN. I think that I would try not to leave someone on it for an unlimited period of time. There is concern about polyps or neoplasia, especially when you're talking about adult patients for long term. So I think trying to cycle someone off of it and seeing how long you can keep them off of it. If you look at the studies, how they did the trials, some of the kids were able to be cycled back into the drug sooner, especially if they started having more symptoms off of it. But I think especially for adults, there can be concerns about cancer, to use this drug long term. I think even with the kids, if you were able to taper them off their TPN, and then you're following those patients closely, sometimes they may need to be recycled. I think we don't know exactly how many cycles it will take or how long it will take. or if every patient can be tapered from TPN. And I don't think everyone can be tapered from TPN using this drug.
You don't think?
I don't think everybody's going to be tapered from TPN.
No, not everybody, but the results are showing that it's
interesting. And maybe as we treat more patients, and it may be the selection of the patients that they have. I must admit, I'm not familiar with this paper, but it may be the patients they picked were those patients who had longer intestinal length versus patients who were shorter. Did those patients have colons? All of these things play a role in what I think that's going to ultimately happen. It would be great if we had a high percentage of patients who could be tapered from their TPN. I'm just not totally sure that's gonna happen with that drug. It would be great if it could. I just don't know.
Okay. Reinaldo, ¿quieres hacer alguna colocación? Su micrófono, por favor. No estamos escuchando.
No, estoy escuchando la conversación entre ustedes. Me gustaría un poquito más un poquito de traducción de tu parte de los comentarios de la doctora, pero
sí,
está todo muy bien.
Porque na verdade, como ella está respondiendo en inglés, no sé si preguntar la pregunta en español hace mucha diferencia, por eso que estoy haciendo la conversa en inglés, porque sus respuestas son en inglés. Mas é interessante que... ¿Cómo?
Hay más preguntas en el chat, José. Están llegando. Hay,
sí, sí, hay una pregunta más acá que se debe manejar. There is a question regarding in a cholestatic patient, if you look for amount of glucose, so as you decrease the lipids, how much glucose carbohydrate do you use in a TPN? If you also decrease the glucose, and how can you really can keep the caloric support for the patient. Então, a pergunta é se reduz também o carboidrato, como que se maneja com a quantidade de calorias, se dá muito mais carboidratos ou se reduz tudo e dá menos calorias para os niños com colestase.
I think centers differ how much glucose they will give, because you're correct. You do have to limit the amount of, if you limit the amount of lipids, you're going to have to increase the dextrose that the patients are getting. The one advantage for having SMOF is that you can give them, similar doses of what you could before of standard intralipid, but again, it's a combination. So that can also potentially help from that standpoint. Some centers, I've seen as high as 20, 25 on their glucose infusion rates, trying to, give them more calories if you reduce the amount of lipid that they're getting. But I think SMOF has helped this with regard to being able to give them more calories than what you were giving them, especially if you were doing lipid minimization.
Yeah. Entonces, esa respuesta es muy importante porque ele está dizendo que lo SMOF, com o uso de SMOF, nosotros no precisamos reducir la cantidad de lipídios. Entonces, se puede mantener el lipídio en la cantidad correcta y se mantener también los carbohidratos, entonces hacer un aporte adecuado. Entonces, ella concorda que el SMOF hace una diferencia para este manejo. Muy bien. There's a question regarding trace elements in a cholestasis. Which trace elements have you reduced? How you manage this? Una pregunta sobre los oligoelementos, los elementos trazos en niños con colestase.
So I tend to worry about copper, as copper has been thought, evidence of copper overload with liver disease. So I tend to take out the trace elements and supplement them individually, in addition to checking levels to make sure that I'm providing them proper nutrients. For instance, manganese can contaminate the TPN. So I don't need to add extra manganese to the TPN. So I tend to take it out and measure the numbers, the serum levels, and then decide how to add it back. I think that, you know, the important aspect is if you take it out, you need to remember you took it out and you need to follow those levels, because you can get in trouble, especially with copper deficiency, with different anemia and other hematologic abnormalities.
Perfect. Other question is regarding the enteral feeding for this intestinal failure patients. You prefer for infants amino acid formulations or extensive hydrolyzed formulations? La pregunta es sobre el manejo con la vía enteral de los niños con intestinal failure en parenteral. Se prefiere usar los aminoácidos o las fórmulas extensamente hidrolizadas?
You know, I think it depends on how the child's doing. I tend to probably see some sicker people, so I probably use more amino acid-based formulas than I do extensively hydrolyzed formulas. If I have a patient that gets referred to me and they're doing fine, meaning they're not having significant diarrhea and they're tolerating their feedings and they're on an extensively hydrolyzed formula, I won't take them off of that. The thought being, you know, there's probably more LCT in some of the extensively hydrolyzed formulas, and also you have more bigger proteins that in theory are making the intestine work a bit harder. Now, some patients don't tolerate it, and I have to switch to amino acid. But if they're doing okay, I will leave them on an extensively hydrolyzed formula.
I would like to ask you regarding the tube. You use tube feeding for infants. I would say it's a newborn that got lose the bowel, then this newborn is going to start in a rehabilitation program. Do you start on tube feeding, or you do directly for oral feeding as a preference? As well as I would like to ask about the human milk, the breastfeeding, if this child, you let them breastfeed. Então, a pergunta é sobre os niños que vão empezar o tratamento como recém-nascidos, se usa alimentação por tubo ou se prefere usar alimentação oral e se usa o leite humano?
So if you look at that PIVCON data set that I talked about several times, only about 17–20% of the mothers actually were pumping breast milk. I definitely would love to use breast milk whenever I can. And part of the thought is you have a variety of factors that are present that are perhaps preventing infection, also different hormones and products like GLP-2 that are present that also may be helping to stimulate intestinal adaptation. The problem typically is it depends on how sick the child is. I always want the child to take something by mouth. So even if it's just dipping it in a pacifier 2 to 3, 4 times a day, I want them to be able to do that, because my goal ultimately is for them to take by mouth. Unfortunately, some of these kids are so sick and they're NPO for weeks and even months that they don't get used to eating. But my goal always, if I can have a child be able to eat, I will do that. Now, I may limit how much they're taking by mouth if they have a lot of diarrhea with their oral feedings, but I will never stop their oral feedings in the hopes that eventually they'll be able to take everything by mouth.
Wonderful. I don't have more questions here in the chat. Do you think that it's okay, Rinaldo, or we can? I have a bunch of questions that I prepared.
No sé cómo estamos de tiempo, Carlos. ¿Cómo estamos de tiempo? We check the time.
Yeah.
I think we should have a little more time. Si quieren, may continue your discussion between experts and maybe clarify some concepts. But
Yeah.
remember, the audience is a Spanish-speaking audience, so try to be bilingual. ¿Okay? Entonces, si quieres, continúa, Spolidoro. Tranquilo.
Sí, pues.
Creo que tenemos un poquito de tiempo.
Uh-huh. I already make a lot of questions that I already prepared, so I'm looking for someone that I didn't.
Well, why don't I ask you a question?
Oh gosh,
That's a good idea.
that's a problem. Go ahead, please.
How often do you have patients that need tapering procedures? Do you have surgeons? And I know Gabriel, I'm blanking on his name, is one of the surgeons in South America, in Argentina, who initially, I think he was in.
Gabriel Gondolesi.
Yes. You know, probably has expertise. Do you have a lot of patients that need tapering of procedures? Is this something that can be offered depending on where you are?
Yeah, I would say we are finishing a Latin American questions regarding in the groups that the rehabilitation groups. We have in this study 23 rehabilitation teams in South America. And the majority do this lengthening procedures. Only in Argentina, they are doing Bianchi procedure. I don't remember any other that described this, but like a step procedure, it's been done in everywhere. So, but not many patients. I'm seeing that's the majority of this rehabilitation teams. They have 1 or 2 or 3 patients with the step procedure. But in Argentina, they have much more experience. Argentina is the top in Latin America in management of short bowel and the rehabilitation. They have the most experience for a longer time. And even now, they are the groups that have much more patients included. Brazil is the second one. We have recently some programs of the health minister for organizing rehabilitation teams. I have an experience because I do this rehabilitation for more than 30 years, and but as it's very difficult money for that, so we don't have much patients. It's very hard for a patient of the public health to go home on TPM, and but with this program of the health minister, the groups that are chosen for that, they have been huge number of. One of the questions was from Dr. Elena Goldani, that's from the same city as I am, and she's one of those programs of rehabilitation from the health minister of Brazil, and she has today around 40 patients outside on TPN, and not only here in our city or our state, and even outside of that. We are developing a very good experience, but really the major things for teduglutide it's on in Argentina, and the major procedures as lengthening procedures are being done there.
Dr.
I don't
Cohran?
know if there is any one of the surgeons, Dr. Lobo, usually to be in this kind of meetings. So he is one of those that have a very good experience. Lobo from Buenos Aires has one of the excellent experience on this. I don't know if he's here.
Dr. Cohran, Dr. Spolidoro is last second coordinator of the Intestinal Failure Working Group.
Oh, okay.
Yes, we have different working groups, and one of them is about intestinal failures. And one of the goals of these working groups is precisely try to obtain data from the different Latin American countries. For example, try to make some sort of census regarding how many intestinal rehabilitation centers are there in Latin America, and now how do you do these certain procedures? What are the pros and cons, the goals and the obstacles that define the way? And that data will eventually lead us to publications, publications regarding our own reality and the way we manage these patients and what we can offer to them. So that's part of what he's been doing, and he has a very interesting data that I'm sure he can share with you regarding Latin America and how
we are going to present this data in CIRTA in next July.
Oh, okay.
The meeting of intestinal rehabilitation. So we accept it as a oral presentation to show this results.
Okay, I will definitely look you up then for that abstract.
Listen, guys, it's been great, but I think we need to say goodbye. Benjamin Gold, are you still with us?
I'm still with you. And in fact, actually, I'm going to throw out a challenge. One of the wonderful things that and I know, Ronaldo, we've been talking about this, Jose and Val, to come out of these series are other opportunities and collaborations. Ronaldo and Jose, I will tell you that I've been pushing Val and Conrad and other members of NASPGHAN who are intestinal rehabilitation experts that it's time for a single topic symposia that precedes the NASPGHAN annual meeting. This year, it's going to be an aerodigestive on Wednesday before the postgrad course. But there's a ripe opening for a single topic on intestinal rehab. And wouldn't it be wonderful if it's NASPGHAN and LASPGHAN group collaborating, showing some data, coming up with some working groups that are sort of transcontinent. Anyway, I think there's just a wonderful set of things that, ranging from Jorge's talk last week and biliary atresia to Val's talk today and intestinal rehab and the work, Jose, that you're doing, where we can really, lock hands and arms and come up with some great collaborative studies and a single topic.
Yes, definitely.
Definitely. Well, yo espero que se encuentren en los próximos meetings. I hope you find each other, Spolidoro and Dr. Cohran, and I hope these sessions open the door to a more collaborative work between North America and South America, and especially taking in consideration the data that Jose already possesses regarding the whole region. That is a general vision of the whole problem and how it's managed. It can be managed in Latin America. I hope this information can be presented elsewhere and for a broader vision of the problem. Bueno, entonces, nada, yo quiero despedir la sesión. Muchísimas gracias a la doctora Valerie Cohran de Chicago, al doctor Spolidoro de Porto Alegre, a Benjamin Gold, que siempre está con nosotros. Muchísimas gracias, por supuesto, a Carlos Timosi, que siempre por su apoyo y su asesoría. Y buenas noches a todos. Muchísimas gracias. Thank you very much, and have a nice and quiet evening. Thank you.
Thank you.
Thank you.
Buenas noches, foi prazer poder trabalhar nessa sessão que foi, a mim parece, muito enriquecedora. Estou muito agradecido, Reinaldo. Muitas graças por ter esta oportunidade. Dr. Valerie, thank you very much for our excellent talk. Thank you very much.
Thank you.
Thank you. Bye-bye.
Bye.